This is the second session in the Activating Research webinar series hosted by NIHR ARC North Thames Academy. I'm Tiffany Wade, I'm the PPI&E lead at the ARC North Thames, and I'll be facilitating the session today, and I'll also be giving a bit of context at the beginning as well. Dr. Sylvie Cooper and Charles Buncharian from the ARC North Thames Academy have both made today possible, so a big thank you to them, and they're also supporting behind the scenes, particularly with the chat function and fielding questions. I'd also like to thank our 4 panel members for joining us today, who will each present their own patient and public involvement and co-production work and the context behind this, and I'll be formally introducing them as we go along throughout the session. So this webinar is intended really as an introduction to PPI&E and co-production. So it's an offering of a range of approaches across the panelist experiences. So it's important to note that some of us will be offering slightly different perspectives, and some of us might use different acronyms. So for example, some of us might say PPI, patient public involvement, and others might say PPI&E, patient public involvement and engagement. And others will obviously speak of co-production. But this is really the beauty of the panel today, as different research will probably required slightly different approaches. And what we hope to do today is to showcase some of the possibilities, but there is certainly no one-size-fits-all approach. So this session is really a broad brushstroke, and in webinar sessions, perhaps further down the line, we will offer a more in-depth look at some of these processes and methods. Today, however, we're going to cover the who, what, why, when, and how of PPI&E. So I'll just share my slides for you. So, like I said, we'll be talking about the who, what, why, when, and how. And if we move on to the next slide, I'll just dive straight in, and then I'll introduce people as we go along. So this is the NIHR definition of the public, and it refers to patients, potential patients, carers, people who use health and social care services, as well as people from organisations that represent people who use those services. So for example, that last part could include, say, a charitable organisation who represents a particular group or community. Now, this is quite a broad definition, which for me, it advocates for inclusivity and multiple perspectives. So the importance of this definition is that it reminds us to consider who is impacted by our research, and that might be broader than we think, and to include as broad a spectrum of stakeholder voices that we possibly can within PPI&E representation. So just moving on to the next slide for the when of PPI&E. So you'll see the research cycle up on the screen, and really PPI&E can be utilized at any and potentially every stage of the research process, but this very much depends on the nature of your research project and the associated funding that you have. So I'm going to take you through the cycle and offer some potential examples of when PPI&E can be utilized along the way, but this certainly isn't prescriptive, and as I said, it will depend on the nature of your research, and so whether you will do something at a single point along this process, at multiple points, or throughout the entire research cycle. So starting at the top of the slide with the very beginning of the research process, with identifying and prioritizing research, an example of including PPI&E within this stage could be running a consultation session where you present your research idea to a panel of patient and public representatives in order to sort of sense check and get feedback on your research. And then that can then lead on to the commissioning. So for example, you can then take some of that feedback from your consultation session and then incorporate that within a grant proposal if you're now seeking funding. And then your PPI&E panel can then also comment on your proposal and potentially offer specific feedback before you actually submit. And then in the designing and managing stage, here you could have PPI&E members form, say, a working group, and they could have input on consent forms or patient information sheets or anything that was really participant facing. They could offer advice, say, regarding on how you design interview questions, or they could feedback on questionnaires and whether these elements were lay accessible and understandable to the general public or the particular community that you're wanting to involve. And then within the undertaking research part, it might be that you have patient and public representatives acting as co-researchers. So they might help with recruiting patients or even conducting qualitative interviews themselves if you're in fact using that method. Disseminating research, PPI&E members could assist with lay accessible summaries of research results, and they might also present these to, say, patient or community groups or at conferences. And then again, in implementing research, for example, if your, say, research developed a new process within healthcare, which is now going to be implemented, public representatives could help explain that process in lay terms, say in documents that you're creating or in any other way. And then on to evaluating impact. PPI&E representatives could collaborate with researchers in terms of actually defining what impact means to them and advise on how to capture the impact of your research so that it's meaningful to the groups that you're actually working with. And then ultimately that might lead you back to more research priority areas that your research has uncovered, and then you would go through that cycle or that process at any point again. So these are just some examples, and certainly aren't prescriptive, but hopefully that just helps you think around who and when you might involve patient and public representatives. So that's the who and the when, and now I'd like to hand over to Professor Monica Lackenpool at UCL's Great Ormond Street Institute of Child Health to share the NEON project, which will act as a case study, if you like, to illustrate how she went about involving patient and public representatives within this piece of work.
Thank you very much. I'm just going to share my slides. It's always a scary bit.
We can see them. That's great.
Great. Thank you very much. Perfect. That's great. Always worry about that. So welcome everybody, and thank you very much, Tiffany and the team, for inviting me and for this very exciting seminar. I'm very close to my heart. Engaging with the community, engaging with the public is obviously something that I've done for a long time because I'm a paediatrician, and that's what we do, is work with families. So it's sort of core to what my own day job is. But as an academic for many, many years, this has been part and parcel of the work that I do. So I hope today I can take you through just some of the learnings and some of the approaches that we've taken. Don't worry about the fact that this is the NEON project. It's just a case example. And what I'm going to talk about is applicable to anything and any project that you're going to do and any piece of work. I won't say a lot about the project itself because we'd be here for another hour. But if anybody wants to pick up on the actual project itself, then please contact me and we can talk about that further. So what the case example is about is, it's called the NEON project. And just firstly, a big thank you to the whole team who's behind me, who does all the hard work that I'm going to be presenting today. So when we talk about whose voice counts, and Tiffany's already given you the whole cycle, and I'm sorry if I now disrupt all the nice, perfect cycle that Tiffany's presented to you. But this is really how I see it. On the left-hand side is the standard, I'm the PI, I'm doing a project, everybody else keep quiet, and I'm going to tell you what to do. On the right-hand side is actually what's lovely about doing public and community engagement, is everybody has a voice and everybody has an equal voice. And actually, if you can see, the PI is probably pushed to the back. They suddenly become less important because, who are we really, apart from trying to get the funding and deliver the research? Actually, it's everybody else's voices that are so, so important. And not having clean lines, not having clean definitions actually helps, because we don't need to put people into silos. We don't need to say we have to do ABC. It invites everybody into the conversation and allows an open, transparent partnership dialogue. So this is the study that I'm going to talk about. And as you can see straight away from the slide, the pictures on the slide, we can see people talking together. So what we were doing was, we were looking at bringing an intervention from the low middle income countries in Bangladesh and Nepal that had been successful there, and adapting it for the UK and the UK context. So already that's quite a big challenge, and we wanted to see how effective that was going to be in the UK. So this is an ongoing project. So you can see the two pictures of the groups of women in the top and bottom. Not that different. We all like to talk, we all like to sit around, we all like to share our thoughts. And this is the study just in a simple slide. And as you can see, the first part is about gathering evidence. The second part is about co-design and adaptation, a very key part of the project. And the third part is about feasibility. And what we were looking at was how to optimize feeding practices in children under 5. So, something very, very important and close to the community's heart. But everything that's driven me and my team in their work has really come from this, about connecting communities. No decision without me. So why should we be doing research without anybody if we don't involve them in our discussions and in the project itself? So we need to be working towards evidence-based and community-centered approaches. And if we're going to do that, we have to engage with the community themselves. And we have to think about local assets and resources that are relevant to them. And we don't know the answers to that at all. So you can see in this slide here, what we were doing was that you can see there are many different levels, and I'm sure the others will talk about this, of community engagement, PPI, whatever terminology you want to use depending on what you're doing. But we actually use the processes to engage with the community at every single level of our work, and I will show you that. So informing the research agenda, informing grant applications, preparing for the study, during the study, and collaborating with the community as facilitators and champions. And there's not one step actually that we don't include, because if we're going to want people to inform us about what's the best research, why would we not work with them right the way through the process? So this is an example of what we did for the NEON study. What we realized was, why should we be bothering doing the study? Why should we be looking at feeding practices at all? So we did a prioritization with the community themselves, what they saw as priorities for research, where we should put our money, really. It's taxpayers' money, where should we put our money? And you can see here that actually the community and the healthcare professionals agreed on some areas of research, but not all, and that's fine. We don't always have to agree with everything. Obesity was a key area, and diet was a key area. Interesting, diabetes wasn't for the families, but that's because they're thinking of diabetes in the long term rather than immediacy for their children. But we realized that obesity and diet was a key area that would prevent diabetes later on, which of course as professionals we were very worried about. So we could bring the two together. And the prioritization workshop was run by the community themselves, and so that we could hear their voices and implement that into the research agenda. We then had 4 pillars of engaging with the community. We, of course, were our UCL researchers, and we had lay advisors, we had people on our team, but we had community members as co-researchers, and I love that word, co-researchers. They were actually with us, telling us about the research, how to do the research, you know, side by side with us. Community advisory group, they were additional to the community co-researchers when we need particular advice on particular issues. And then community facilitators, who were actually there to help throughout the process in actually delivering the intervention itself, but also in creating some of the toolkits that we actually have developed, and you'll see that later as well. We have a film, I think it's been cut off the slide, but there is a film which the community created with us, which helped in recruitment of participants, but also raising the profile of the importance of the work we were doing. And you can watch that on YouTube. So as you can see, what were the different ways that we engaged with the community? We thought it was important that the community led the problem solving for us. If we're going to write a grant, if we're going to do a protocol, if we're going to do the research, the community helped us with our problem solving, because we are not embedded in the areas of where we were conducting the research. We wanted to make sure that all the tools that we prepared were acceptable, and that's only the community can tell us that. It was very much led by the community, telling us what we should be doing rather than the other way around, if we go back to the second slide that you saw earlier. And we wanted to make sustainable change, and it's not sustainable unless we do it the right way, that it's going to be acceptable to the community themselves. So in our first piece of work, we adapted the intervention from overseas, and part of that adaptation involved the community telling us how we should adapt the intervention. There was no point us adapting it and thinking, yes, we should do it this way or do it that way. But you can just see a few of the bubbles here of what people said. You know, how will extended family members be involved in the groups? Should we have men groups separate to women's groups? Should we have combined groups? I mean, you know, we get at the cultural context and we have to be very sensitive. How are we going to adapt the tools to make the tools sensitive? We were using picture cards, and on the picture cards we had drawings. Well, how do you make those drawings relevant to everybody in the community who you're going to show them to, and how they can feel comfortable with the pictures you're showing? And what do communities think about a group approach? Would they talk in a group, or would they not talk if you brought everybody together? and how can we maximize acceptability and accessibility? So those are just a few. I mean, we had loads and loads of things people said. And some of the things we learned and we would have done wrong if we hadn't engaged with the community were things I've already talked about. You know, where should we hold the community intervention? Should it be in where there's a creche? Shouldn't there be a creche? Should there be, what day of the week should it be? Do we have to think of holidays such as Ramadan or Diwali, and when should we actually do this so people would engage in it? Should the intervention be led by community facilitators or health professionals? Who would the community listen to? So lots and lots of learnings that we did before we even got into the study itself. So in the first part, when we were doing our formative study, this is really how we worked with the community. I've talked about the prioritization workshops. I've talked about informing the adaptation. And now actually in the early formative and feasibility study, we worked with the community as facilitators, recruiting participants, working with us to analyze the protocol, telling us how we should do the research. The PPI representatives were all invited to the quarterly research meetings. It wasn't like they were separate, everybody was together, everybody had respect for each other, and there was a study accountability and a partnership role. We had advertised through local organisations for the PPI members. So again, this was formally done with an advert, asking for people to be part of our team, recognising their value as part of our team, but also respecting the amount of time they were going to have to give to us, and respecting the fact that people are doing this in their own time, so they need to know what they're getting into, and we should be telling people that, not just expecting people to come along and when we feel like it. We took back some of the key findings so that we could then verify and validate our findings with the community as well. And here you can see some of the things that we developed. We also developed a toolkit. That's another part of the study. And this toolkit, again, was developed and led, really led by the community. So as part of the intervention, we wanted to develop picture cards. And so you can see just very few examples here of the picture cards that we were developing. But the wording was very important. Would people understand what these cards were saying? Would the pictures be relevant to them? Would we offend anybody? We developed posters for recruitment and posters about the project. And interestingly in that is, we use very nice soft pastel colours. Community were like, nobody's going to look at that poster, you better change all the colours. So they actually created the posters for us in a way that they felt people would actually pay attention to them. We created a community manual as well, a facilitator manual, which they again interpreted in their own way to say, this is how we would read it, and these are the words that you should use. And the most exciting thing is that we actually have created a recipe book with the families. So just to really, I'll move quickly on. We've nearly finished, so I think we can have a discussion if there's time. But really, I was talking about the community assets, really, that the community know the assets, they know their community. Some things to think about, community facilitators, during COVID, it was very, very difficult. Community engagement does not have to stop, and that's why I wanted to come back and talk to you about this. During COVID and lockdown, community engagement can continue. And we did this by moving everything online. Community didn't have to move. We used Zoom. Of course, we've seen the digital problems with that, but it meant that community could still feel part of what we're doing. The participants actually liked it because they felt they had flexibility in terms of time and dates and how they could engage in it. So there were lots of benefits of doing this actually. And meetings could be recorded, and then the facilitators could go back actually and hear what they had to say. So really, I did leave only just before the end, which was just to say this: as an individual, I can do nothing, but as a group, we can find a way to solve problems together. So happy to answer any questions that you have.
Thank you, Monica. That was, I think it was a really beautiful example of, you know, how to involve communities and patients and public in research. So thank you for sharing that with us. And I've just let everybody know that I'm really aware that you've got another presentation directly after this. So firstly, thank you for doing 2 in one day. And I'd like to also open up the chat to everyone if you've got any questions. But one thing I think might be helpful is, do you have any sort of top tips for people? So we do have a kind of a comment in the chat section is about, feeling rushed and trying not to have, involvement be sort of this tick box exercise. Do you have any tips around that?
Yeah, I think it's building relationships, and the key for me was always about spending the time up front to develop relationships. So being honest with people, like I said, about what are they getting involved with, actually reaching out to where is comfortable for the community to work with you. So I think there is a danger when we're in the NHS running PPI in the hospital or running PPI in our venues. Well, actually, we should be going out to the community, and we were holding all our meetings out in venues where the community felt comfortable. So we were going into their space rather than coming into our space. Relationship building, like I said, and doing a little bit of thinking beforehand about what are the challenges for the community to be part of your PPI. So we have another project where we have children under 5, and mothers are having to rush off to pick their children up. It's very busy for them. They have their own challenges in their own life. So I think if you can work before you meet people, do a little bit of your own homework, understand where the community coming from, understand what works for them, and then develop a very strong relationship. And once you get that relationship right, everything really flows on from that, I think.
Thank you. That's brilliant. I think we'll end there just due to time, but thank you so much for your time, and we really appreciate you being here. And it's just a fantastic sort of case study to illustrate to people. And good luck with your next presentation. I'm sure you don't need luck, but thank you very much.
Thank you very much. Bye, everyone.
Thank you. Right. So shall we move on to Christine, who will be joining us. So it's Christine Menges from the CRN. Have we got Christine's slides on that? Great. Okay. So it's Christine is joining us from the CRN North Central Thames, and she's joined by Sarah Brown, a patient and public representative, who will also share some of her experiences from the patient and public perspective. But we'll start with Christine first. Over to you, Christine.
Thank you very much, Tiffany. Okay, yeah, as Tiffany was saying, yeah, Christine Menges, I'm the PPI lead for the local network North Thames. And so I've been given a very brief, like 5 minutes, so I will give a very brief, just sort of taster about what you can do to initiate PPI, and I'll also share some tips and resources about ways that I can help you. Just before I start, I just want, because I always point out to people I haven't met, I do have a stammer actually. Sometimes it's worse, sometimes it's better. So just that might take longer to say certain words. So that added to a possible internet connection, it can be difficult sometimes. Anyway, moving on. Okay, now I've just got one slide where I'd like you to do a little bit of work, as it were, if you don't mind, because I'm assuming most of you are quite new to actually doing any PPI. So I just I just wanted to get a flavour, if that's okay, Tiffany. I wanted to perhaps ask there's quite a few participants here. I don't know whether they can either add to the chat or they can even sort of speak. As I say, I just wanted to get a feel. I'm assuming that most of you have not done any PPI, but I just wanted to to check what you think the definitions of these three different things are. So first of all, can I ask, would anybody like to have a stab at how they define patient and public involvement?
Does anyone have any thoughts on that?
Yeah, don't be shy. Just put anything into the chat, or even, I don't mind if you take yourself off mute and have a go.
So we've got involving patients in research from someone. We've got the use of the public with relevant expertise, getting involved in the design of the study.
Yeah. Okay.
We've got
that's correct. Actually, that's totally correct. It's about working with members of the public and involving them in the design and the delivery of your research. So yeah, that's great. Now the second one, what do we mean by participation in the context of research? This is slightly different. Participation. Anybody like to have a stab? Again, I've not got any sweets. There's no right or wrong. Well, there's a right answer. Would anybody like to have a go at participation?
Does anyone want to have a go at that? So somebody's written being a participant in a study. Someone else has said actively taking part as a member of the public.
Okay, I'll just stop there in the interest of time. The first definition is correct. It's members of the public actually taking part in a research study. Okay, so it's when you consent to take part in a research project. And the final one is patient and public engagement. I know there is a slight overlap with involvement, but in my area of work, I do separate them, and I'll come on to that in a minute. But yeah, would you like to have a stab at what we mean by public patient engagement? No.
Anyone want to add?
Okay.
So somebody is talking about research for mutual benefits. Somebody else has said that it suggests something less meaningfully involved. And then other people have said share their experiences.
Okay, that's a really nice broad selection, actually. Yeah, in its basic terms, it means members of the public actually talking about research, whether that's from their own participation, from their own involvement in research, or whether it's simply talking to other people about the importance of supporting research. So thank you for that. Now, because as I say, I've just got 5 minutes. I'm just going to basically touch on the bare bones of PPI. Now, PPI, patient public involvement, covers a wide spectrum of different activities, but basically it's it can be anything from consulting with one or two patients of the public who have the clinical condition or lived experience that you want to focus your research on, compared to at the other end of the scale, it's co-production, which Monica gave a lovely illustration of, and Nicola Hutchinson Pascal will be talking about a bit later. But that for me, co-production is really the creme de la creme, I would say, of of PPI. That's when there's a joint ownership and shared responsibilities right from the inception of the research study all the way through all the different parts of the research cycle. But as I say, I'm assuming that most of you are actually quite new to PPI, so I wouldn't actually advise that you jump in at the deep end, as it were. I would actually advise that you start small to gain some experience and confidence. So I've listed one or two ideas of where you could start. My first suggestion would be simply to talk to your local PPI lead, your local trust, or your local NHS body. If you don't have such a lead, then you could talk to your R&D manager. I'm sure that they could help advise. For example, if there's any patient advisory groups within that trust, you would be able to tap into, for example. You should also speak to your colleagues, find out if any of them have carried out any PPI, and would you be able to, perhaps consult with any of their, lay representatives or patients that they've used, ask for advice, I say, from your working colleagues, rather than starting from scratch. I would also actually suggest that you could put a brief flyer and a brief role description together. That's quite a nice way for you to help focus your mind and to advertise actually locally as to exactly what criteria you're looking for in local members of the public, local patients and carers. So make it brief, as I say, but I think actually that would help. You could ask your local NHS body to advertise, using these materials, as well as ask your colleagues. Another way of finding people is, of course, you could link in with a medical charity. Obviously, depends on the on the group that you're researching. Another possible area you could reach out to is local community groups. So I would advocate that you try and get as wide a group as possible from a more diverse group as you possibly can. Okay. Now, once you've been able to have found some people to be involved with your project, what should you ask? Now, it's really important that you think about this and you think about the value that these members of the public are going to add to your project. But just for some starter questions, you could ask them first of all, well, as someone with lived experience, what questions should I be focusing my research on? Do you agree? Are these appropriate questions in my draft protocol? For example, what things are important to you? You could also say, what do you think of my current draft objectives? Are they meaningful? Can you suggest any more pertinent endpoints or objectives? Ask them, is this, is my draft study design, is it practical? Is it workable? Would you be able to, for example, come to the hospital, go to the GP surgery this many times at this, a day, a week or whatever. So really get them involved. Ask, how can my plain English summary be improved, etc. There's loads of questions you can ask and about meaningful discussion with the right people. There's another one here. What do we need to include in the patient information sheet? So hopefully, as I say, this list will give you a list of starting point. Now what's our role in helping to facilitate PPI across the North Thames network? Well, I do a bit of hand holding. I'm not able to just set up groups myself, but I do get approached by a few chief investigators, and as I say, I do give them some advice. I hold their hand when I can. I suggest where they could approach groups of local patients. I send them useful updates and resources. And this is a great link here, which will be shared with you later. But this is it's a link to the NIHR update on supporting PPI. But and within this link, there's lots of other links, which include how to reach out patients, how to deal with reimbursing members of the public, etc., etc. So this is an extremely helpful link. I also signpost chief investigators and research teams to training. I strongly encourage all researchers to do some basic PPI training before they embark on any PPI. And this, the very fact that you're attending this session is great, but I would also advise that you do some additional training. Both of these bodies do excellent training. UCHBRC do great online 2-hour sessions on a selection of PPI. RDS London also do free online training sessions, so please have a browse. And finally, I do occasionally ask my great team of volunteer research champions if they would like to get involved in doing PPI for specific projects. So my final slide is, hey, who are these champions? Well, basically, within North Thames, I've got a really lovely sort of group of champions who have been suggested to me by local researchers, by local research nurses across our North Thames partner organisations. They're basically members of the public, patients who've participated in research themselves, are enthusiastic about research, and are happy to talk about the experience with other people.
Sorry, Christine, I said that I wasn't going to interrupt, and now I'm interrupting you.
Okay, sorry, okay.
I think this might be a good time to move on because we've got 2 more speakers.
Sure, that's fine.
Actually, I think Sarah can speak about her role as a research champion, and she can actually talk about it from that perspective, if that's okay. Again, I'm terribly sorry. I think we've got a lot to cover today.
That's fine. No, that's fine. Yeah.
So thank you for that.
No problem.
So I'd like to move on to Sarah Brown, who's actually a research champion within the CRN, and she's also a patient and public involvement representative. So I don't know if you can see both of us. Sarah, are you there?
Yes, I'm here.
Hi, Sarah. So if you could kind of talk us through why you've become a research champion, what that looks like, and what your experience of being a PPI rep has been.
So I became interested in research when I became ill myself, and my condition is poorly understood, poorly recognised, and research got my diagnosis for me. And it also meant that I have used the research to raise awareness about my condition amongst clinicians who care for me, and also my wider community of people who live with my condition. And ultimately that's improved my care and hopefully improved the care for others. And I've been asked to comment on research projects involving my condition. It took me off to the British Heart Foundation because I have a heart condition. That's the first place I went to. And there was nothing about my heart condition on their website. And I ended up being one of the first lay members of the British Heart Foundation Clinical Studies Committee. I didn't expect to get there, but that's how I got there. And with that, we were involved with looking at the research applicants' public and patient involvement, which was their plain English summaries, the way they had designed their projects, and we got very good at sniffing out whether it was a tick box exercise or whether there was genuine and meaningful patient involvement, because it came out in the questions, and we would submit an evaluation and ask the researchers to answer our queries and questions. But we also made suggestions. We also tried to be positive as possible, so it was a two-way communication.
And can you give, can you also give some examples of like when, projects you've been involved in that went really well and that you would say, really included people rather than that tick box exercise?
So with COVID, there was an enormous, massive explosion of research, and it was noted that PPI, public involvement just fell off the map almost, and we got very concerned about this. And I was invited to be a member of the research advisory group for the London School of Hygiene and Tropical Medicine, and they did a COVID-19 study, and they had a different approach. They got us in as a group right from the beginning. So we looked at the research, and they sort of wrote the plan with us as we critiqued it. So because we as patients have lived experience of the condition, we could give them sort of quite sensible advice, and sort of we saw a potential barrier. One of the part of the study was for them patients to withdraw their blood pressure tablets for 2 weeks, and we all went, if you tell me to stop taking my tablets, I'm not going to do it, because we have this bombarded with everybody said don't stop taking your tablets, and we thought that patients would be reluctant to do it. So they listened, and they strengthened the safety checks for the patients, the way that the researchers would contact them, and they also strengthened the exclusion criteria so that people potentially who shouldn't be in the trial, when it would be dangerous for them to be, the trial were withdrawn or wouldn't be in the trial. So that was a sort of, we were doing it together rather than the plan being written, us coming along and saying you should do it this way and rewrite it. It was done together. So it saved them time, because we have very, very little time to get this turned around because of the COVID.
So it sounds like it was a truly collaborative experience.
It was, and it went further than that, because, and I will give you the reference, the researchers have actually published a paper of their experience of working with us in this situation, and the research advisory group, we critiqued the article before it went to publication. So it's true, rounded, the whole thing. And I will send in the reference so that you can read it.
Brilliant. And before we move on to Nicola, any top tips you would like to share for people, from the patient and public perspective when they're involving people in research?
Get your patients in there right from the beginning. We should be your fourth thought, not your second thought. Not a tick box exercise, but it comes with challenges. And the challenges is when we go in there, we are effective, we are critical friends. And that means that as researchers, you may not hear things that you want to hear because you've done this beautiful design, and we'll come along and go, perhaps you need to tweak that. And that can be painful. And we have lots of, and as research advisors, I see people and you see them go, oh no, I didn't think of that. Oh my goodness, that means I have to redesign my study. Avoid that. We're not a hindrance. Patients will bring a depth and an insight to a study because we want that study to succeed. Because when you get it right, when you do research that is relevant to us as patients by listening to our experience as patients, it will mean that studies are more likely to succeed. As I say, we want them to succeed because ultimately it means that our quality of life will improve. So listen, seek us out, and don't be frightened of us. And when you have us all in a group in a room, don't forget the tea and biscuits.
Excellent. I think the last part was probably the most important. Thank you so much for sharing that. And people, everybody who's attending, please feel free to put any questions and chats for Sarah, and we'll hopefully have a few minutes at the end of the session. But I'd like to move on to Nicola Hutchinson Pascal, as we seem to be kind of quickly running out of time. Hi, Nicola. Nicola is joining us from the Co-Production Collective. Thank you very much for joining us today. And rather than any slides again, Nicola and I are going to be having sort of just a conversation around co-production and why it's important. So whilst we're starting, could you just maybe talk us through what the Co-Production Collective is?
Sure, yeah, and hi everybody, it's a pleasure to be here and with my fellow speakers. Co-Production Collective, we're basically a support service for those wanting to co-produce research, service or policy development. And we ourselves have been co-produced from the start. By that I mean a mixed group of people have been involved in the setup, that being patients, members of the public, researchers, and also from charities, students, really anybody is welcome to get involved in what we do.
Brilliant. And so I guess it would be good to explain, define co-production for people from your perspective. So what does co-production mean to you?
Interesting. So we try to not too heavily define it because we really want everybody to get involved in working collaboratively. But what we say is that it's about working in equal partnerships for equal benefit. And we don't actually define it further than that, but we do talk about the fact that it's all underpinned by certain values that we try to live and breathe. And for us, those are about being human, transparent, inclusive, and also challenging the system as well.
Nice. And so for me, it almost sounds like it's a way of working or sort of an ethos rather than a prescribed process. Would that be right? Okay.
Yeah, definitely. And there is a saying that you sometimes hear, co-production is a way of being, not doing. And I think that is so true. It's sometimes a bit of a weird thing to talk about, but if you live and breathe those values, then you can really embody it in everything you do. And the people that you work with become part of your team, not an addition. Those members of the public or patients are part of your research team for this work. And it's really important you consider them in that way and you treat them in that way, and you don't treat them as an add-on or an additionality.
I think
that's a word.
I don't know if
that's a word.
Sarah was saying as well.
Yeah.
Sorry, there seems to be some feedback. I'm not quite sure where that's coming from. If everybody could just make sure that they're all muted, that would be great. So, Nicola, what do you think? Why do you think co-production is important in research then?
So I think it's important for so many reasons, and a lot of them are very similar when it comes to patient-public involvement and engagement work. I think there's a lot of overlap. I think the big one is that it really enables a situation where a mixed group of people, including researchers and patients, can work together to design, manage, undertake research to do that whole research cycle together. That isn't necessarily saying though that, you know, you can't co-produce if you don't do everything co-produce. You know, you can also, if there are elements of work where, you know, I don't know, something has already started, but you realize you should have been co-producing, you know, you can learn as you go and develop, and that could then, you could then start from there to co-produce. But ideally, you would start from the outset and you would be working together collaboratively. So it's a massive benefit to do it that way. I think it makes sure that research questions are really relevant, and that the priorities, I think somebody's already talked about this, you know, reflect the needs of those that are affected by whatever it is the research is looking at. And it will, without a doubt, bring additional expertise. This team that I talked about, where everybody's part of one team, you know, different skills and experience, but research experience is no more or less important than lived experience. It's all equal and everybody's there around the table, which obviously brings lots of challenges. And I'm happy to talk to people about how you break down power differentials and those kind of things, but I don't have time, unfortunately, to go into that today. A few other things that I think means, or is why it's important, are assessing ethics and if I could say that, assessing ethics and acceptability of your research. I think, you know, working in this way really helps with that. And also, it's a real good way to check and challenge that you aren't falling back into kind of established ways of working, and actually you're pushing the boundaries, and your research is new and different, and you are actually open and accessible to all in what you're doing.
And are there any sort of case studies or examples of co-production that you could kind of illustrate to people so they have an idea?
Sure. Yeah, I mean, I think one really good example from some work we've been doing about that kind of one team I talked about is a project called Hearing Birdsong. You have a great website if you Google it, or maybe somebody can put it in the chat. But so they were a team that came together through a kind of innovation event where people met each other and shared experiences and pitched for some money. And that team was a mix of an architect, some researchers, some patients, and some students as well. And the challenge that they'd been asked to address was, for those with mild to moderate hearing loss, was about improving communication when they were in a healthcare setting, so that you didn't get kind of situations that you sometimes see at the moment, where it can be a quite negative experience, perhaps, for somebody who is deaf, for example. And so what they did was they developed something called Hearing Birdsong, which is a bird box that the architect designed, and in it sits a mobile phone that plays different pitches of birdsong. And the idea is that can be in a healthcare setting for people to listen to. And if you can't hear certain pitches, that means there is certain things going on with your hearing. And this came about because a patient in the group had identified she knew she'd lost her hearing when she couldn't hear birdsong anymore. So that whole idea that they developed and is now doing very successful work in healthcare settings came about because of a team that was a co-production team. And they allowed that, as a team, different ideas to come to the fore and embrace that approach. And they got so much more out of what they were doing by doing it that way.
I think that's a really beautiful example of that. So it's similar to the question I've posed before, but slightly different. Why do you think co-production is beneficial to research?
There's all sorts of benefits. I suppose I would say it gets research out of the ivory tower, for want of a better word, out of its kind of isolated situation, which it sometimes is in. And it means that actually the research that is done is much more practically applicable and useful. And I think if co-production is meaningful, then the actual involvement of people in it will be beneficial. But for this to happen, we've talked about these things already. It needs to be well planned, paid for. There needs to be a diverse group involved. It mustn't be tokenistic. And you need to involve people from the start and allow that kind of power sharing and decision making. But in terms of other benefits, I think that that practically applicable piece, you know, if you put it in that way, it's much more useful in the long term. It leads to that research that's beneficial for the patient groups involved. And I suppose an example I can share around that is some work that we did with an organisation in Somerstown, which is called Action Youth Boxing Intervention. And it uses cognitive behavioural therapies and various other therapies to work with young people using boxing, non-contact boxing as a medium, to help them to engage with learning and education. And actually, they, with the young people and a researcher, co-produced a study to look at the impacts that they were having as an organisation, which was really valuable for them. And it meant that actually the work that they were doing could be shared more widely, and actually they could reach many more people. Please tell me, Tiffany, to shut up if you need me to shut up, by the way.
This is really interesting. It's fascinating. And we do just have a couple more minutes. So I wanted to just ask if there are any other questions from the attendees to, you know, to pose to Nicola or to Sarah or to Christine before we wrap up. And I guess while we're okay, so we've got best practice tips for feeding research findings back to the community. Sarah, would you like to pick up that one, or really anyone, if you've got any thoughts?
I think that your patient, you know, your patient PPI group, the focus group can help, and also social media, Twitter, and we're all fans of Twitter, Facebook. We're not at the moment being able to meet face to face, but I'm sure it will be back one day. So word of mouth within the patient community is an effective way of disseminating usually good research, especially if somebody's participated in the research.
Did anyone else want to comment on that? Okay.
I just actually like to reiterate what Sarah's just said. Actually, I was going to say exactly that, Sarah. I think if the research findings can be, you know, discussed and disseminated by by a contributor, a champion, and then I think the messages are going to resonate much more strongly, as opposed to just the chief investigator standing up there who hasn't got necessarily he or she got the lived condition or experience themselves. So yeah, no, that would be my advice. Was that?
Yeah, I think that's fantastic advice, Christine. Nicola, did you want to add anything to that?
No, I think they've covered it.
Okay, we've got 2 more minutes, but there's another question about examples of how you've handled conflicting views of research priorities. Well, that's a big question for the last 2 minutes, but any maybe very brief bullet points that we could add, even though, like I said, it's a massive question.
I would say it's about building relationships and trust as a group and working together. You know, so it's fine to have conflicting views, but working through it and actually trying to prioritize. But in order to do that, you need to build that trust and relationship.
Sarah, did you want to pick up on anything?
Yeah, I was thinking that because a lot of, interestingly, patients value quality of life sometimes over length of life. And there's a big conflict between the hard outcomes that some clinical researchers want, which is, you know, for cardiac, heart can be sort of 30-day mortality after a procedure. And I did sort of say, well, actually, it's not just that. It's about how the quality of those lives that you live after the intervention. And sometimes you can stop people in their tracks when you actually say, well, this is what it feels like to be a patient. We've got this lived experience. With the greatest respect, the view from the bed is very different from the end of the bed. And sometimes you just have to hold your ground, and sometimes they'll go off and have a think about it, and then they'll come back again. But you can't get in a fight. You have got to keep that relationship going. You've got to keep communication, and you've got to accept sometimes you won't win every time, but maybe you'll do it next time. So you just chip away.
That's brilliant. And I think we'll end it there. We're bang on noon. But I think the key message is really what I hear from the group is involving people right from the start, nurturing those relationships. And the more you involve people, those relationships will develop. And seeing people as equal partners and collaborators with multiple perspectives. So thank you so much, everyone. Apologies for some of the technical problems. I think we've had brilliant presenters today, and thank you for everybody attending. And we will, I know Sylvie and Charles will send out a lot of the links that were discussed today, and do get in touch if you have any other questions. And hopefully if we haven't covered anything that you've asked, we can take that forward with you directly. Thank you again to our panelists. This has been brilliant. I know we've tried to cover a lot in quite a short amount of time, and hopefully in maybe a future session, we can dig a little bit deeper. So thank you again, and everybody have a lovely day.